Okay, so we're going over the case on tennis elbow. In case you're wondering, the hat the hat, it's an ice pack on the Impact logo, celebrates January, which is National Hangover Month. So I thought we should celebrate it and have as many as you possibly can this month. Anyway, what we've got is a 37-year-old male office worker complaining of pain over the right lateral elbow. So it's about where you would expect it there. He's had it for about 3 weeks. The onset was gradual. He can't think of any reason for it. He plays tennis a couple of times a week for an hour or so, an hour and a half each time. And he's been doing that for about 2 years. Previously, he played much more, sort of every day, but he's got busy recently and he's cut back. The pain's got bad to the point where he doesn't want to play. He can play, but he doesn't want to play because he's not enjoying it because of the elbow pain. So what we need, of course, is your diagnosis and the etiology. Okay. So first, the diagnosis. I'll be the candidate, I'll also be the examiner. So what I'll do is, what I've asked you to do basically is ask the examiner the questions and then ask for the results of specific tests. So we're looking at the diagnosis. My first question will be, where's it hurt? Well, we already know that. And what bothers you? Is it using your hand, using your elbow, using your whole arm? Is it gripping or what? And the answer to that is, yeah, it's gripping. Specifically, I'm having trouble working on the typewriter. I'm having trouble gripping now as well. And playing tennis is giving me trouble gripping the racket. Okay, so is it tender? Is it common extensor tender? Tender? Yes, it is. Okay. Isometric wrist extension, painful? Yes. How painful? Moderately painful, and the tenderness is moderate as well. Good. Okay. All right. Well, pretty much that's my diagnosis. Common extensor tendinopathy, I would say it's a tendinitis. The tenderness is moderate. The pain on isometric wrist extension isn't painfully weak, and he can function. Is there any aching after you do stuff? Not really. A minute or two afterwards, but nothing long term. So this is almost certainly a tendinosis rather than a tendinitis. Okay, so let's have a look at bias correction here. We'll run through the differential diagnosis and we'll eliminate them. I'll use negative differential diagnosis to correct for bias by eliminating these differentials. So the first one would be radiohumeral joint dysfunction. We can do quadrants for that. I expect it to be negative. Similarly with radio-ulnar, superior radio-ulnar, and with the ulnar-humeral joint. So the quadrant should be negative on testing there. After that, what we're probably looking at is referred pain, in which case the tendon wouldn't be tender and isometric testing would be negative as well. So this isn't referred from the neck, it's not referred from the joint, it's not joint pain. So I'm quite happy with my diagnosis. It's a common extensor tendinosis. Okay, so these two tables summarize the diagnostic process and bias and error correction. So the question was, is gripping painful? Basically, using the hand rather than using the elbow, rather than using the neck. Is gripping painful? The answer was yes. How painful? Yeah, it's bad enough, but I can do it. Palpating the tendon is moderately tender. Certainly not exquisitely tender, is not screaming it when you get near to it. Isometric wrist extension is strong and painful. It's not breaking, there's no reflex inhibition, no pain inhibition there going on. So the diagnosis is common extensor tendinosis. To correct for bias and error correction, as we said, the differentials are tendinopathy, common extensor tendinopathy, radiohumeral, radio-ulnar-humeral biomechanical dysfunctions, and referred pain from probably the neck, possibly the shoulder. So the testing for this is lack of tenderness of the tendon with tendinopathy, the quadrants are negative with the joint problems, and if this was referred from the neck, all of these testings locally would be negative. Plus the fact there's no topographical link between the elbow and the neck, that is, the pain doesn't run down the arm. Can happen, but it happens very rarely. So this would help me basically look for availability bias, confirmation bias, anchoring, and everything else that's going on there. So that's my bias and error correction. As far as staging this is concerned, we're looking at it being a tendinosis or a tendinitis. So if it's a tendinosis, we're going to have moderate pain with no post-sharp pain aching afterwards. Whereas with tendinitis, you're going to get severe pain with aching after you've heard it. Non-obligate impairment with tendinosis, obligate impairment with the tendinitis. Moderate tenderness of the tendon, exquisite tenderness of the tendon. No pain or a mild pain on stretching the tendon, but no spasm, while with tendinitis you're going to get moderate, more likely severe stretch pain, and that's going to occur probably with spasm. There's no painful weakness with tendinosis, there is with tendinitis, and no obvious history with tendinosis, and an obvious history if not part of a disease process. That is, if this is a rheumatoid disease or gout or something else that's going to cause inflammation of the tendon and enthesitis, then there will be a history of this. Okay, so staging this is fairly easy. Everything we got from the patient screams that this is a tendinosis. Okay, now the etiology searches. So in general, what we're looking at here is neuro and neurophysiological, causing weak extensor muscles or a structural weakness of the extensor tendon. Hyper or hypotonic extensor tone. Probably this is about the weakness more than it is about the tone. And then we've got mechanical problems, abductor ulnar and wrist joint. Hypomobility causing reflex inhibition. So as usual, we've got reflex inhibition, segmental facilitation, and AXT problems in the form of fatigue or weakness and or trophic malnutrition. So I'll show you how I would go about answering the question, what is the etiology? Okay, I would start the etiology search via mechanical stressing. So what was the result of testing for the elbow quadrants? Negative pain and the ovoid was normal. What about the wrist quadrant? Positive pain and the ovoid was abnormal. Okay, so I'll then do a biomechanical exam of the wrist, and what was the result of that? There was a positive palmar subluxation of the scaphoid. Okay, now I'll test for segmental facilitation C6. What was the result of that? There was weakness of the C6 muscles, and you couldn't properly test wrist extension because of the pain, so you couldn't break it to look for reflex inhibition. But the pain was screwing up, but it was a bit weaker. So anyway, C6 segmental facilitation was present, and the confirmation test, tone, reflexes, they were all what you would expect for segmental facilitation. Okay, I would then look for reflex inhibition, wrist and elbow. It was found at the wrist. Okay, so having found all that, I would then wobble the spine for segmental facilitation. Does that improve the segmental facilitation? Yes, it does. Okay, and then I would wobble the wrist for reflex inhibition. Does it improve that? Yes, it does. Okay, so because I've got a segmental facilitation problem, I would then screen for segmental facilitation. Did I find anything by doing only quadrants in the neck, quadrants at the shoulder, quadrants at the elbow, and I know that the wrist is painful. Everything was negative except for the wrist. Okay, so my conclusion is that the segmental facilitation is coming from the wrist, so that can be ignored. The reflex inhibition was coming from the wrist and not from the elbow, because the elbow basically didn't have any reflex inhibition there. So the reflex inhibition is almost certainly a result of the subluxation rather than the cause of it. So my conclusion for the etiology is that this is being caused by the subluxation in the wrist. Now, this is reflex inhibition that's causing this, not the hypomobility in the wrist, because the hypomobility in the wrist will allow full extension of the wrist to occur. So the wrist is going to be capable of going into its functional position for power. So it can't be a limitation of extension. Wrist flexion doesn't affect the extensor tendon. So this is almost certainly all reflex inhibition. My treatment from all of this would be to basically treat the local pathology at the elbow, the common extensor tendon. So that would be ultrasound, high dose ultrasound, frictions, eccentric contractions, and so on. For the wrist, manipulate the wrist, then rehab the movement. So here's the summary of what we just talked about. The elbow quadrant was negative for both pain and an abnormal ovoid. The wrist quadrant was positive for both pain and the ovoid. So a biomechanical examination of the wrist is necessary. Showed up a positive palmar subluxation. So it's a biomechanical dysfunction present. Going to test for segmental facilitation. I expect to find it because of the wrist problem and the pain in the elbow, and we do. We find evidence of weakness and tone changes and reflex changes and orange peel skin, all the stuff you'd expect for segmental facilitation. For reflex inhibition, there is reflex inhibition. We find that if you like, flexion and radial deviation was weak, extension and ulnar deviation was weak. So it was patterned, it was a breaking weakness, so that's what we got there. Wobbled the spine to see what's happening for the segmental facilitation, to confirm it is segmental facilitation, and that improves. Wobbled the wrist for the same reason, that improved. So because of the segmental facilitation, to make sure it wasn't coming from elsewhere other than the elbow and the wrist, we screen for nociception. As we said, quadrants in the neck, quadrants in the shoulder, quadrants in the elbow, quadrants in the wrist. And basically, everything was negative except for the wrist. So what I said to you was that segmental facilitation wasn't a cause of this, it was a result of the pain. And so we can basically ignore it. And the whole thing is caused by reflex inhibition from the wrist, because the wrist is subluxed into flexion. It's not going to limit extension, which causes the overuse in the tendon, or if you prefer the other reasoning, it doesn't change the length-tension relationship of the extensor muscles for its functional position. So that's a summary of it. Okay, if you look at the way I answered that question, both for the diagnosis and the etiology, it didn't leave the examiner much to do other than simply respond to my questions about the history and the test. This is what you want. You do not want the examiner probing you and questioning you, and the examiner doesn't really want to do that. They just want to sit there, let you blur it out, and then only ask questions where there's some doubt in their mind that you really understand what you're saying. So don't make them doubt it. You've got all the information, look at it, get it out there, and don't hesitate. Just say it. The more you hesitate, the more you look like you don't know it. And a lot of the time you do know it, you're just second guessing yourself. So don't do that. It doesn't work very well. And once you get flustered by the examiner, it's a hell of a job getting back to the course that's going to get you through this exam. All right. So work on processes. It's all about processes. Work on your process, and then how you're going to present that process to the examiner. It's as simple as that. Now, in the real oral practical, you're going to be doing stuff as well. You're going to be doing techniques, assessment, and treatment techniques, which may actually make things a little easier for you. but just you've got to get your processes in place and you've got to be able to explain yourself. All right, guys, I will talk to you soon. Bye.